Good afternoon, everyone, and welcome to today's COVID Echo session. I'm Susan Bryan. I am the Senior Director for the Greenhouse Project. And I can't believe it, but today is session 11 of 12 sessions. So really excited that you joined us for today. And our session today is really about the role of leadership in census recovery amid the pandemic. I mean, goodness sakes, I know that everybody has been hit hard with COVID and the impact on your census. So we're going to talk today to some exceptional leaders who have determined ways to build census, to recover post-pandemic. And you'll get to meet these folks in just a minute. I want to talk first of all about how much I appreciate the ECHO model. The ECHO model is where we really leverage technology, in this case, the Zoom platform, to be able to identify and share best practice to a big group of people, to be able to do case-based learning or scenarios to learn from so that we can monitor and manage our outcomes. And we can all teach, all learn, we can all get better. So to get us started, I'd like to first introduce my colleague, Janet Wright, and she's gonna just review a few housekeeping and logistics for you. Janet?
Hi, thank you. Welcome everyone today. The chat box we will be using down at the bottom of your screen. We'd like you to please go in and introduce yourself and the name of your organization in the chat box. If you have any IT issues, you can also put that in the chat. And then we will be using that chat box as well for our Q&A part of the session. You will be in listen-only mode, so you aren't able to speak, but that's why we'll use the chat box for any questions that you have. We ask you please to share your webcams with us. We'd like to see your smiling faces while we're on here today. And just so you know, the session is being recorded, so the recording and any links to any resources or that we've shared during this session today will be sent to you tomorrow. And I think that's all. Thank you, Susan.
Thank you. And again, please introduce yourself via the chat. We really do want to. That's the mechanism by which we virtually connect with one another. I also want to ask Mary Hoffner-Thomas, my colleague, to introduce herself. Mary will be working with me during the Q&A. And after each of our presenters speak, Mary will be able to kind of take some of your questions. So Mary, you want to just say hello to everybody?
Sure. Hello, everyone. Welcome. Glad that you're here. And if you have questions, again, we'll want them in the chat box.
Great. Thanks, Mary. So Janet, you want to show the map and then we're going to launch a poll. We're going to do a poll. We'd like to know what part of the country you're calling in from. So Janet, if you launch the poll, and just take a moment to tell us which part of the country, the region where you reside and where you're calling in. It's always interesting to see where people are calling in from. Okay, Janet. Well, once again, it's the Northeast. Last time we did this, I believe it was the Southeast, but not quite half of you are from the Northeast and 27% from the Southeast. I'm always curious to see where we've got people calling in from outside the US, and about 6% of you are calling from outside the US. That's awesome. We welcome all of you from wherever you're calling in from. And now I'd like to introduce our hub of experts today and those that will be supporting us. I want to ask Dr. Power to introduce himself, to say hello to everybody.
Hi, everybody. This is Al Power from Rochester, New York, a geriatrician, and I've been doing educational work with the Greenhouse Project. I'm having some technical issues today. My power cord died about an hour ago, so I'm trying to navigate an iPad, so if I'm a little clumsy, sorry about that. I also have a meeting at 4, so I may jump out a bit early, but it's great to be here. I'm looking forward to what everybody has to say.
Always appreciate your words of wisdom. And speaking of words and wisdom, we've got the distinguished Jewish Home Family Group today. So Eric, you are our regular, so I'll have you introduce yourself and then to invite your esteemed colleagues.
Sure. Good afternoon. Thank you again for having me. My name is Eric Ruggiero, Director of Nursing at the Jewish Home at Rockley. We're located in Bergen County, New Jersey. Thanks.
And Carol, you want to introduce yourself?
Sure. I'm Carol Silver Elliott. I'm President and CEO of the Jewish Home Family, which is the parent organization of the Jewish Home at Rockley, where I have the privilege of working with both Eric and Naomi. Jewish Home Assisted Living, Jewish Home at Home. And it's always a treat to be here with all of you.
And always a treat to learn from our friends there. And Naomi, last but not least, love to hear from you.
Thank you. It is an honor and a privilege to be a part of the Jewish Home Family and a joy to be sharing all this with our greenhouse family. I'm Naomi McDermott. I'm the Director of Social Services at the Jewish Home of Rockley.
Wonderful. Welcome to all of you. And we'll introduce our didactic speaker in just a moment, but let's do another poll. We just completed the holiday, Thanksgiving, and we're just curious, how many elders went out of the nursing home where you represent for Thanksgiving? None, one or two, more than two, or you're not sure? So I'd love for you to take a moment and just answer that. We did this poll before the holiday, and it'll be very interesting to see how many actually had elders that did go out and what numbers there were. All right, Janet, you can close that poll. Well, overwhelmingly, nobody went out. And I think, Dr. Power, if you remember correctly, that was kind of your words of wisdom, that it's not a good idea. So it looks like certainly that was a recommendation taken. About 13% said more than two, and 20% said you really weren't sure, and 10% maybe one or two. Difficult decisions to make at this time, that's for sure. And we're going to, there is a question that we want to be able to ask you and try to get some ideas. How did your care community celebrate Thanksgiving? And you can put those answers in the chat box. Just really curious. And we're not going to unpack it right now, but would just really love to know what you did, what some of your communities did to be able to provide some sort of festivity for the Thanksgiving holiday. And then we'll revisit those later on. And our final poll, and I know I apologize, we're moving quickly. We've got good content today, and I want to make sure we get to it all. This is our greatest challenge poll. So Janet, thank you. What has been your greatest challenge in the past 2 weeks since we have met? Has it been PPE, the use and supply, testing, visitation, census recovery, staffing, elder engagement, or COVID outbreaks, or developing a vaccine administration strategy? This is a single choice, and so we'd love to know what the single most significant challenge over the last couple weeks. All right, you can end the polling. Well, it's no wonder you're on this call today. Census recovery. It looks like 29% said that was the most significant, but very close behind that is staffing at 26%. COVID outbreaks right behind that at 26%. Visitation strategies, 10%. Developing a vaccine administration, 6%. And if you hang to the end, we're going to talk a little bit more about vaccine. We have Dr. Jonathan Evans, who will join us at the very end to just give us kind of 5 minutes to really talk about where we are with the vaccine and distribution. And he'll give us kind of some of the latest, greatest information on that. All right, I am excited now to invite Dr. Jim Wright to the COVID Echo session. And we learned a lot from Dr. Wright and his experiences at Canterbury and Richmond, Virginia. So Dr. Wright, I'm going to have you introduce yourself, and then we're going to turn the presentation over to you.
Great. Well, thank you, Susan. It's great to be with everyone today. I am a geriatrician in Richmond, Virginia, and a great admirer of the greenhouse model. I met Susan and Janet at a greenhouse convention in Florida back in the innocent days before COVID, and was struck by the model and very energized by that. So today, though, I'm going to talk about my experience and my recommendations for census recovery in this time of COVID. So is it okay if I share my screen, everyone? Great. All right, great. Hopefully you can see my slides. Yes, great. So again, my name is Jim Wright. I'm a member of a small group of geriatricians here in Richmond, Virginia called SNF Long-Term Care Partners. I am medical director of 2 facilities here in Richmond. When COVID struck Virginia and Richmond in particular in March of this year, I was medical director of a facility called Canterbury. We were in the news, national news, for many months. And just for reference, our outbreak occurred 2 weeks after the Kirkland outbreak. So this was certainly the first outbreak in Virginia and one of the first outbreaks in the country. And so I'm going to share with you the knowledge that I gained during our time of COVID and the census recovery that we experienced following COVID. I'm also president of what's called the Homecoming Group, which is a group of geriatricians and elder care specialists that are looking to bring the first memory village into the United States. And I will give you just a flash of information about that at the end of the talk, because it's my pet project and I love it. So. All right, so Canterbury Rehab, Richmond, Virginia, just west of Richmond, Virginia. We are a facility of 190 residents. On March 11th, we had 166. Our first infection was a few days later on the 14th. We unfortunately had penetration of COVID throughout most of the building. Our infection rate was 84%. So out of that 166 residents, 140 became infected, and unfortunately 51 of them died within a 6-week period. So our mortality rate was 36%. And remember, this was in the days where we had very little knowledge about treatment for COVID. Hospitals were overwhelmed at that point. We had difficulty in transferring our patients from the nursing home to the hospitals, as they really felt there was nothing they could do for patients. And so we had a very high rate of death as a result of ignorance and just the system being overwhelmed. So by the end of our outbreak, and of course we weren't accepting patients during the 6 to 8 week period of our outbreak, but at the end of our outbreak, we had 110 patients out of 190 usually. And of course, no one in their right mind wanted to transfer to Canterbury Rehab after a hip replacement or a pneumonia or anything like that. So we had to find our niche during that time, and our niche, of course, was COVID. And so we started marketing ourselves as a COVID center that specialized in COVID recovery to local hospitals as well as surrounding facilities. For example, we partnered with a number of assisted living facilities that, of course, were very nervous about managing COVID in their facilities and simply did not have the resources to do so. And so we took active COVID cases from surrounding assisted living, and then we advertised to our surrounding hospital systems that we were ready and able to accept any recovered COVID patients that they had. And so we basically fulfilled the rather empty niche of a COVID center of excellence in Richmond, Virginia. So we started those admissions about 10 days after our last resident passed away from COVID. So it was pretty quick. We were still, of course, on emergency footing at that point. And really, in many ways, we were at the top of our game as far as treating patients with COVID. Probably, more able to do so than anywhere else, any other nursing home in Richmond because of our experience. So I want to just quickly, and I know I only have 9 minutes, essential elements for successful census recovery. 5 elements that I'm going to run through quickly here. Define your team, align your team, vet your protocols, be present, and communicate. So the reason I say define your team is because you have a number of stakeholders in your facility. The most important, in my opinion, is the on-site team, and that is your medical director, your administrator, your director of nursing, your infection preventionist, maybe your director of nursing. Don't forget your frontline staff. When you're developing protocols, they need to be vetted not only by your medical director, but by your frontline staff as well, and they need to be at these meetings. But your off-site team is very important as well. Canterbury was owned by a company called Marquee. It's owned by a company named Marquee. They have a number of facilities throughout the Northeast, and they have an excellent corporate structure that was very, very helpful during our crisis. But they are stakeholders as well, and they have an interest in, of course, building up your census. They have an interest in making sure that the protocols that they have developed through their corporate medical director are put in place in your facility as well, and your regional director is involved. So your team is perhaps bigger than you think to begin with, and that team has to be aligned. So aligning your team along these 3 pathways: risk, science, and mission. And the number one thing that I became aware of while we were developing our protocols and dealing with the outbreak in the early days is that everyone has a different comfort level with risk. And coronavirus represents a risk that many frontline workers have not seen before, the risk of contracting a deadly disease. And so some frontline workers and administration members were very shaken by this and needed to be convinced that this was part of their job. Science is another important thing to be aligned with. So you need to pick what source you're going to use. We were very firm with reviewing CDC recommendations, WHO recommendations, and very little else. Because there was a lot of information shared by news outlets and good journals, and studies were coming off the press every day about how COVID spreads, how COVID is treated. And we made a decision early on that we were not going to use early studies to guide our treatment or guide our use of PPE. We were going to use CDC guidelines. So for example, the CDC was resistant at the beginning to emphasize how easily COVID spread through airborne particles. They felt that the epidemiology of the disease pointed towards spread through fomites, so large particles, and through person-to-person contact. So we focused on protecting our team by focusing on that method of spread instead of airborne spread. And that helped the team to align with a common purpose and a common way of protecting themselves, instead of kind of diverting all their attention to all the many possible ways that COVID could be spread. And then your mission. What is your mission? Is your mission to entrench and protect yourselves and protect the patients that are there, or is your mission to extend your expertise to the community? And we felt that our mission was to spread that expertise. Instead of entrenching, we were able to accept folks from Northern Virginia, Southwest Virginia, hours and hours away as our COVID center of excellence. Protocols. You cannot revise and review your protocols enough. They have to be developed by your medical director, director of nursing, your corporate medical director, And then you have to run them through your frontline staff, your unit managers. Is this practical based on your personnel and the PPE that you have? You have to educate your staff, especially your frontline staff, with every single revision. You have to re-educate them when you do another revision, and you have to monitor. Protocols don't just happen from a piece of paper. They're living, and those pieces of paper should be living documents. Presence. You are not going to successfully implement your protocols without being there and monitoring, walking the hallways. Every single member of the administrative and medical teams needs to be on site, if you can, walk in the hallways, making sure that PPE is donned and doffed appropriately and that protocols are being followed. This is very, very important. And as you know, staff turnover is very high during times like this, and new people are coming in all the time. Communicate. So doesn't matter how good you're doing, how good a job you think you're doing. If you can't convince the surrounding community you're doing a good job, then you're not going to build your census. So of course, the hospital caseworkers, they need to know. The area, like I said, assisted living facilities need to know that you're accepting patients. Residents need to know what you're doing. Why are these new people coming in? Why am I being moved? Why are we setting up new hallways and not letting people go into those hallways? Families, of course, need to know probably daily from the facility what's going on. Frontline staff, of course, and the press will always be wondering what's going on inside your facility. So, leadership skills that are important to have and to carry with you in this attempt to build up census again. Team building, and make sure you know what your team is. Consensus building, make sure you all are aligned with those three elements: risk, science, and I'm trying to remember the last one, mission. Sorry. Your professional expertise is very important. Presence, and communication, to make sure that what you're doing is communicated within the facility and without the facility. And if you want to find out more about what we're doing in Richmond to improve the life of elders and help to prevent something like this happening again, please look us up at homecomingrva.org. Thank you very much.
Thank you very much, Dr. Wright. And Mary, I'm going to ask you to share what questions might have come up. And I would invite you once again to put your questions there. And while Mary's pulling those up, I'm going to first ask Dr. Power, is there a question that you would have of Dr. Wright?
Thanks so much, Jim, for your presentation. It's hard to imagine what you went through during those 6 weeks when you had such a crazy time with so many people getting sick. But obviously it forces you to make tough decisions. I really like the way you outlined risk and science and mission. And I'm just wondering, because we hear a lot of discussions about this, can you maybe just give one example of a case where you thought it was best to take on a certain type of risk in order to balance with something else, or where maybe you changed your protocol in a way that maybe took on some risk in a way that you thought would be overall better for folks?
Mm-hmm. So a particular case where we took on or revised our protocols in order to assume risk. Yeah. Well, I can tell you this. I put the emphasis on defining your team early in the slide because our team wasn't well defined at the beginning. And I actually, unfortunately, found out that we were accepting active COVID cases on a Friday evening as the first person arrived, and was sick. So unfortunately, that was a Friday evening that was spent scrambling and revising our COVID ward. We had a patient that came in from a hospital that had not been tested for COVID, but came in with a respiratory illness, and sure enough, ended up having COVID. And we had to quickly figure out, okay, we have a person that could have COVID and definitely has a chance of exposure. Do we put him on the COVID ward and just make sure that he's isolated in his own room? Or would that be dangerous to that patient? Should we put him on the warm ward for people that have been exposed. And if we put them on the warm ward and we have a great suspicion of his, being positive, are we putting all of our other patients on the warm ward at risk? So we had to, I think it was a time of great creativity. And we put him at the edge of our COVID ward, near the warm ward is what we ended up doing. And I had to make that decision that there was enough risk for him to have COVID to do that. And sure enough, he did have COVID. So it came out okay. But yeah, that was
thanks. That's a great example. I mean, there's no risk-free situation, and it's a great example of how you had to make those tough decisions. Thanks.
Yeah.
Thank you, Dr. Powers. So Eric, I'm going to go to you to see what questions you might have for Dr. Wright.
Dr. Wright, that was a perfect example of how to rebuild census in the building. We experienced it actually on springtime. It took us like a good 3 to 4 months to rebuild our census, and aligning the protocols and all our initiatives is a lot of work, because as you said, everything takes a lot of risk. Admitting residents or elders that are coming from the hospital and they have like let's say a COVID test or 5 days old. So how do you know that this elder is safe enough to come in? And how do you know? We
kept on reminding everyone that this person could have caught COVID on the ride here.
Absolutely. And we experienced that. We did. 5 days old of COVID test, and then all of a sudden, the latest test, the next day when the elder came in here, guess what? Positive. So you really have to be careful in cohorting the elders. You really have to specify what unit, who are the staff who's assigned to that cohort. It's so important. And again, this doesn't happen overnight. You really have to strategize. It's
talk about it every day. Yeah,
it's a lot of work. Also, what we experience is establishing same treatment protocols that was with them. We spoke to the medical chief officers in our neighboring communities and hospitals, what they're doing and how are we going to keep the elders as much as we can and manage our elders so we will not burden the hospitals as well. So you have to develop that sense of trust. Yeah. And that takes a while to build relationships.
And I think that's part of your mission as well. If you see your mission as being a good partner in the community instead of, a place that just can't afford to treat COVID, then you will help the whole community. Yeah, that we saw that as our mission as well. We will manage everything we possibly can. Those that we can't, that should be in the hospital, we will send them. Yeah. Otherwise, we're gonna do it here, and I think that's very true. Very important.
Right. And also, what you said, educate and re-educate. Lastly, you cannot really emphasize enough how important it is that from hand washing to assessing respiratory symptoms. You have to keep emphasizing to the staff, these are very important in combating this disease, this virus, in order to prevent it from spreading. I mean, until now, what we've been seeing is we've been dealing this for 8 months now. You see the COVID fatigue with the staff members, just even with the masking, you can tell they're very hyper vigilant, and all of a sudden you can see month by month, they're getting a little, relaxed. Exactly, getting down and down. So you really have to constantly educate the staff members, and it's an ongoing process. And again, we've all been experiencing this, which is again, it's continuous, and you have to be very resilient.
Yep.
Thank you.
Thanks so much for those great comments. And Mary, I'm going to go to you because I have seen a few things come through chat. So you want to share a couple questions for Dr. Wright?
Sure. So one of them was, do you think that your essential elements are relevant for communities that really choose a different niche? So when you listed those, is that just a universal kind of thing? Or?
Yes. So if you choose a different niche, which I'm assuming is not being a COVID center for the region, what would that other, that niche is no longer a niche. That's a huge, like your normal mission is to accept patients from the hospital and make sure they have a safe and effective place to do rehab and that kind of thing. So protocols are still very important. Education is still very important, but you're not going to be on a crisis footing. You're not going to have to juggle and take those patients in that have COVID and make sure that they're separate from the people who never had COVID. stress levels will be much lower, and your staff turnover rates will probably be lower as well. So, so all of what I said is true, but it will be on a much less, intense level. Protocols are always important, right? There's plenty of other things to use protocols for, but you're not going to be, on a war room footing with your team every day. So.
There was another question that talked about when considering the built environment moving forward, would you implementing any changes in design or the configures, the equipment, anything like that? If you're, and I guess, you're almost in that.
Gosh, yes. I've used my, my unenviable platform as medical director in one of the most deadliest outbreaks in the nation to really advocate for changes in the built environment, and mainly and simply providing elders with a room of their own. So trying to raise awareness in the public of how warehousing elders really not only is dishonorable, but now is deadly, right? And so making sure people are aware of what's going on in nursing homes that generally have, nursing homes are not at the top of the list of important news stories, usually. So this is our opportunity, and my opportunity, to make sure that people hear and know what's going on, and that the solution, even though, yes, it does involve expense, is pretty simple. Let's give our elders a room of their own and a bathroom of their own. That's all, that's the very least we can do to honor them. So if nothing else changes from this, that one thing could make a huge difference in preventing a pandemic like this from occurring in the future.
So I'll do one other one that someone had asked. They said, what did you do with the elders who lived at the home but had survived that first outbreak?
Right.
And were they then separated? I mean, that's like a logistical. How did you handle that at the home?
We call them our precious ones, or our golden ones. We of course only had 26 that never contracted, or at least the PCRs were always negative. And so we had some of those were in the dementia ward, unfortunately. So we had two floors, dementia wards upstairs and the normal long-term care is downstairs, and we had an entire wing on each floor. Those doors would be closed. They would be monitored. The dementia ward, of course, folks, we had trouble keeping them in that hallway, but whenever possible we would. But they would be in that hallway. They could go to the doors of their rooms, but they were isolated. Everyone would be wearing PPE to protect the elders from themselves when they went into those hallways. And so we were just so very, very careful with those elders. And it worked. We had 2 elders out of those 26 that eventually did contract COVID, unfortunately, but the rest of them we kept safe through the whole thing. So we would talk about them on a regular basis, and really, I really feel my heart's full for those folks, but we really took responsibility for them.
Thank you.
Jim, thank you. What you've been through. And I think every time I've talked to you, I think we kind of get to that place of emotion when we realize the devastation that COVID has taken upon some really precious souls. And so thank you for sharing your story, your experiences, and the lessons that you've learned to really be able to, address some very practical things. So stay tuned, and I want to now invite my friends from Jewish Home Family to share their experiences. Different part of the country, a little further north from Richmond, Virginia, but I'm going to turn it over to Carol, Eric, and Naomi. And what I appreciate about the 3 of them doing this is what Dr. Wright was suggesting, is that it really is a team approach, that it's not one person going in to do something. So I'm going to turn it over to Jewish Home Family and talk about what you all needed to do.
Thank you. Thank you, Jim, for that presentation. We're going to take a slightly different approach, but I think the 2 pieces are going to fit together rather well. in northern Bergen County, New Jersey, where we are located, we are literally feet from the New York border. And when COVID began to really penetrate in New York, one of the places it started was Westchester County, which is close enough to us that if you had a good arm, you could probably throw a rock and hit it. So it came into our buildings. We had our own battles, and we won't go through what all of that was about, but you know, to this day, I talk about April as the 5-year-long month of April. We had a lot of COVID among staff. We had a lot of COVID among our elders on both campuses. And we lost some people that we still close our eyes and see their faces. So it has been a tough go. But I think what Naomi and I want to talk about today is census recovery and rebuilding, not just from COVID, because there could be a lot of reasons for it. And I know from the work I do with Leading Age, that even folks who have not had COVID in their buildings have had an issue with census drops, largely because of the terrible beating that nursing homes and other residential facilities have taken in the media, as well as, and I won't, I promise, get on my soapbox about this today, but as well as the issues that people see with the enforced isolation that has taken place in all of our buildings in what we can't fail to say is a violation of people's human and civil rights. So we all have had some rebuilding to do, and we all have had a place to grow from. Both of our campuses suffered significantly from a census perspective, both because we lost folks, but also because we were closed to admissions for a period of time, and early on we discharged people to make sure that they were safe. So when we finally began to stabilize, it certainly was the process of recovery that we had to get into. Next slide, please. One of the things, and Jim alluded to it in a slightly different way, before you can rebuild, you have to make sure that your organization is really ready. And you know, it's any product that you might be selling, if you will. If you don't have a product, you have nothing to market. You have to know that you have a strong product, that you can depend on it, that if people do sort of put aside their fears and anxieties about coming into our setting, that we are going to make it everything that they hope and wish it to be, that we're going to keep them safe, that we're going to help them heal, that we're going to be there for them. And whether that applies during the middle of COVID, as you can see our amazing team here, a fraction of our amazing team here, or whether it applies when we are not in a COVID circumstance, that's really the critical thing. You know, we're in the people business. We provide care, but it's all about people. That's bricks and mortar, and who cares? It's all about the people, and that's what really matters. I love this picture because this gives you a sense of not just our team, but the spirit we have. People started decorating their PPE, and people had these great slogans on their PPEs, as well as unbelievable artistic ability. You know, I'm lucky if I can draw a circle, and these people were doing these logos and stuff that were amazing. So we ended up in the midst of all the craziness having a PPE fashion show, and people decorated their PPE and they strutted their stuff down the hallway we call Main Street that you can see right there. And, you know, maybe it was 10 minutes out of our lives, but it made people laugh and it made people smile, and it gave them a renewed energy. And quite frankly, the elders got a big charge out of the decorated PPE all the way along. But team and having that team in place is critically important. Next slide, please. The other piece of this we talk about is trust. Our communities have all looked at us as providers and said, yikes, you know, the New York Times says nursing homes are death pits. We're reading, that's an exact quote from a headline I woke up to on a weekend morning. We have been really demonized in so many ways, and it's really difficult for us, has been difficult for all of us to rebuild the trust of our communities, our families. I will tell you, I don't think we had to rebuild much trust with our elders, because all of them know us. All of them have continued. Some days the strength that we drew came from the elders more than any place else, who supported us, who believed in us. We have a woman who was in our COVID cohort. She's almost 100 years old. She's a Holocaust survivor. And she said to the team repeatedly, this will pass, you know, compared to what I've lived through, this really isn't anything. Keep it in perspective. You know, those are the moments. So we did a lot to make our team feel connected and positive so that they were also radiating that positivity. We had months of having meals for the staff provided by generous donations. We made our cafeteria free. We did a lot of things. But this is one of my favorite things. We had these hero shirts made, and on the front they say Jewish Home Hero, and on the back they say smiling under our masks. And it happened to be a gorgeous day. We all went outside and we were doing hearts with our hands. You can see the back of me there showing hearts with our hands, because we wanted to show just the energy and the strength. And it's an image that we've used over and over to show not just ourselves and our board and our family members, but also our community, that we're here, that we're strong, that we're ready, and that you can count on us. Next slide, please. One of the things, and Jim said it also, that has been really important for us is to be transparent. And I think that's a lesson in leadership that applies whether it's COVID or anything else. But we made the decision from the get-go, crisis communication 101, is that we had to just say it. We had to be out there with the facts, with the truth, in a really thorough and calm way, because people need to know and people have the right to know. And if they're going to trust us with their loved ones today or in the future, they have to know that we're sharing with them everything we can. So on the left side of the slide, you see our family letters. Every time anything happened, we wrote a family letter. If we had people who were diagnosed, if God forbid we had a death, if we had staff diagnosed, whatever it is, we wrote a family letter. And I wrote those letters. They were co-signed by our medical director. Our response team reviewed them all before they went out, but we emailed them out sometimes daily when we had to, and we, in a real effort to keep people informed. I will tell you, we got many, I still get many positive emails from people thanking us for the letters, for being honest with them. We also, during this period, appointed nurse liaisons for each of our campuses. We had a designated nurse liaison at the nursing home and one at assisted living with a specific phone number that was available 24 hours a day, 7 days a week, as well as an email address, because sometimes, especially when we were in the thick of things, the nursing staff was running, and they couldn't stop and answer that telephone. And a family saying, what's going on with my loved one? I don't know what's going on. I'm frightened. So this way we had two experienced RNs who were always there to say, I'm going to find out right now. One of the other things I'll mention as we're looking at this on our website, and any of you are welcome to look at this, we have a COVID-19 tab. Under that tab, we have every single one of these lots and lots of letters archived. We have our outbreak response plan. We have all kinds of information because we want people to have ready access to it. And that's a really important thing for us to make available to people. We work very hard on keeping connected. We work very hard on answering questions. We did a number of family Zoom programs. Again, keeping ourselves in people's consciousness so that they could see exactly who we are and what we're all about. Next slide, please. We also, of course, then, as things stabilized, began to renew our marketing. And we took our marketing in what we felt was a kind of a soft but hard-hitting approach. We really wanted to talk about our successes in caring for people with COVID, in the way that we managed, in the way that we were able to really help people heal. So we used those things and created this series of 4 ads that talk about those things that are important parts of of what we know. Enriching really addresses the issue of isolation and making sure that people feel connected and have a sense of purpose, even in the days when we were really confining people to their rooms. Healing is an obvious one. Nurturing, again, is the recognition that even while people are being isolated and while times are tough, we are caring for people in more than just a here's your medicine, or here's what we're doing on our COVID diet. And strengthening, in times when we don't have COVID, we're able to run rock steady boxing, which is what you see in the picture with our dear friend Barbara, who has Parkinson's. Rock Steady is a program for people with Parkinson's. As soon as we knew that we were going to have to close our doors in mid-March, we pivoted and we're running our boxing programs live streamed twice a day, every single day, because again, we want our folks to stay connected with us. We want our folks to continue to get well and to stay strong. Next slide, and I'm going to turn it over to my lovely colleague, Naomi.
Well, thank you, Carol. So finding new ways to do outreach. I think we all know the world is now a virtual place. It's bricks and mortar here, but it is virtual. And outreach has to shift with the new reality. The first thing I'd like to mention is a website. Carol showed examples of ours. People need their websites to be interactive. They need to have chock full of information, and chock full of good information, not just marketing information. It's no longer about selling your buildings. It's selling your soul practically, because to bring people in, they have to have a level of trust with you. And people who never looked at websites are now looking at websites. The next is we have to be virtual in all sorts of ways. It used to be when pre-COVID, if you would have told me, listen, set up a studio and do your in-house stuff, we probably would have hired someone. But today, look at TikTok, look at Facebook, look at all these virtual platforms. Everybody can do it. It's very user simply and very easy to do. So get yourselves out there virtually, and not just about filling beds and coming to us. It's about recognition and letting them know who you are. Jewish Home Family does a lot of community service that may or may not result in the need of filling a bed. And even if we don't fill the bed or the apartment today, people start to know and trust that we're here to do the right thing. We partnered with our local libraries, because in our Zoom kitchen, we do cooking classes. We have our boxing program that Carol already spoke about. We have our virtual support groups. We have our own blogs, which are conversations, 15 minutes. We have many, many different platforms and different ways we're looking. We're also very much so on social network, and we promote that our staff can share what we do here through their own social networks, and that gets very, very real. So again, it's about having it out there and being part of a new and different virtual platform. And of course, virtual tours. And I don't mean click on the link on my website I see. I mean, let me take my phone, let me do it with you, let me answer real questions in real time. Let's set it up as Zoom so that all 6 kids can see where mom may be. And let's do it and work at it together. That is a wonderful way of building that person-to-person relationship and that contact. Next slide, please. Next slide. Thank you. We are open 7 days a week. One of the challenges with families today is everything is a crisis. Everything is a crisis. Mom is sick, they're in the hospital. We need to be able to calm that down, because by the time families come to us for services, they're in problem management, not crisis mode. But we need to educate them on how that differs. And we need to help them understand that we're not a crisis. The big thing about a crisis is families always want to talk to a doctor. What can the doctor do for me? Well, In the reality of healthcare today, it's not about the doctor. The critical importance of our nursing team and the critical eyes and ears on the floor that see you 24/7 a day. We need to teach families how to appreciate that and what they are. Again, it's our job to make sure that they can breathe, and that's what we want them to do. Empowering staff is a big part of how we can help our families stay connected. And to train staff on doing things that are out of their comfort zone. There's a legal codicil I put on. I'm not a doctor, I'm not a nurse, I've been doing this for a while. And having that empathy and ability to help someone stay calm and know that there's always someone here they can talk to. The other piece of that is it's not just one person that'll give them the answers. We all can give them the answers and we all cross-train. But again, not a crisis, a problem now. We'll get through it and we'll get through it together. Next slide, please. Keeping the family engaged is unbelievably important because we are their eyes, we are their ears, we're their soul, we're their heart. We need to get them to trust us. We send them our newsletters. We tell them, these are the numbers you can call. This is what you can do. If I'm not here, there's 3 other people who can answer that for me. And even things like our front desk people, they know and can tell what's going on. One big tool that we use in-house is texting, not to families, but to each other. When a family needs to get to me and the nurse can't find me at my desk, they text me and they know I'll respond. And that's another way that the team here works so well together, is making sure that we have each other's back. The other thing is listening to families. Families have so much to say to us because they've got so much time on their hands. Listen, listen, and listen, and be compassionate. We know it's a crisis and not, but the families don't know what's a crisis and what's not. So we want to listen, give them that reassurance, and then listen, and then listen some more. And do it with compassion. Not the old, oh my God, I can't believe Mrs. Smith's daughter called me again. Maybe what I'm feeling, maybe what she's done, but to her, I need to keep her engaged. And I may be the only one that can do that. All staff here have been empowered to be that one who can make a difference. Next slide, please. Caring. I gotta tell you, loneliness is such a huge, huge piece of recovering and a huge, huge piece of making everything as okay as it can be in this world again. And compassion and reassurance, and it's no longer about just caring for the people who we service. It's about us caring for each other and the ability to have that empathy. Eric already discussed how we're so tired of putting on a mask. We're so exhausted. Being a hero is no longer any fun. You know, being a superwoman is not what we signed up for. It's not what I want to be. I'm just tired. And caring for each other and getting each other through that moment of exhaustion is so important for us. One of the things that we teach each other is it's really easy to be tired, but we're only going to be tired this moment and then it's gone. And if things go wrong, we fix it. And if something happens, we're there. And that cheerleader doesn't just have to be the leader. It can be anyone here. We have amazing leadership at the Jewish Home Family, but I can also tell you we have amazing line people, and sometimes it's that line person that is the one who makes the difference. So caring for each other, it has to be a family. Yes, it can be a piece of bubble gum, it can be an apple pie, and believe me, toilet paper sharing really was caring back in the day, but we need to take care of all of us. And it's not just, we got this anymore. It's, I understand this, I appreciate this, and I care. Sometimes it's as if I haven't hugged anyone in forever. And I'm a hugger, and it's hard. And sometimes just that simple touch of someone I know has been tested 48 times is all it takes. We reassure, and as much as I reassure you, I'm reassuring me at the same time. We're all going to be okay. Carol?
Thank you. Last slide, please, Janet. Naomi and I could go on for a very long time, as you could probably tell, but we won't. We simply wanted to share some of our thoughts. There are many more. My contact information is here. You're certainly welcome to reach out to any of us. You know, these are challenging times, and I think as much as our team has come together to support one another, I know that we as Greenhouse have come together to support each other, and we want to continue to do that. So thank you for this opportunity.
Well, thank you so much, Carol and Naomi. And I think from what Dr. Wright has done, Carol has done, Naomi has done, you've really demonstrated the role of leadership to really get in there and lead in a transparent way and to lead in a very proactive way. So I'm going to just see, Dr. Wright, I'm going to ask you first if there's any questions that you would have of Carol or Naomi.
Oops, I'm unmuted. So I love your website and how you mentioned you had a COVID-19 tab. Was that available for families to scroll through and look at all the communications that have been? Okay.
It's updated every time we do a new letter. In New Jersey, we have an essential caregiver program where people can apply to come in for visits. The application is there. We published our whole outbreak response plan in detail, put it on our website. It's all right there for families or anybody else to see.
That's great. That's a great resource, and I'm sure that was reassuring to families. When you guys worked on rebuilding your census, were you particularly targeting COVID patients, or how did you do that?
That's a good question. No, we weren't necessarily. We have been willing to take COVIDs, and we've continued to maintain cohort areas for COVIDs, but we have also taken people who do not have COVID. We interestingly are seeing people coming in for subacute and then converting to long-term care at higher rates than we've ever seen before. And the one picture that I was hoping Naomi would identify, you saw sort of the smiley face with the glass in her hand. That happens to be the head of discharge planning at one of our key hospital referral sources. We developed our own COVID diet. We were giving people smoothies and milkshakes constantly to keep them hydrated and calories up. So then we said, well, you know, we've gotten so good at smoothies, let's take them out to the hospitals. So we took them out to the hospitals, gave them a cup as well. And that was the picture she sent us with the smiley face. Again, using the things that maybe were part of the struggle, flipping them in a positive way. So
yeah, that's
fantastic. We're also heavily marketing assisted living because we took a hit in census there too. And both buildings, thankfully, are coming back up.
Right. Thank you.
Thanks for that. And I'm going to ask Mary if I just could do one question, and then I'm going to ask Dr. Evans to join us. Mary, do you have one question for us?
So there were so many, but I think that it's, Carol, you talked a little bit about like your census is coming back. How quickly did that happen? And what would you say was like the number one, challenge, I guess, to getting people to come back, you know?
It's been interesting. It's been about a growth of 10 per month. So we normally are very, very full. And of course, we were not very full by any stretch. So we've been moving up and holding about 10 per month. I think the biggest challenge has been, the fear that people feel. And the second piece of that is that quarantine period for the first 14 days. So we've made a real effort to try and enhance virtual visits. During those 14 days, The windows on the first floor have numbers all over them so that families can window visit more easily, as well as on the upper floors. And in assisted living, people who are in that 14-day quarantine are not in the apartment they're going to live in long-term. They're in a special welcome suite that we set aside on the first floor, so they have window visit access. As well, they have special program of meals, of hallway visits to make them feel engaged. And we are writing off their costs for those first 14 days as an incentive to get them into assisted living. So we've been very aggressive in that rebuilding.
Wonderful. Thank you for that. To your point, I think we could go on and on. There's so much to learn from both of you, from all of you, and really appreciate your being willing to share. I did want to save just a few minutes at the end. I think hot off the press is obviously the news about the vaccine, and that priority will be given to long-term care residents. And so I'm going to get out of the way. I'm going to introduce our good friend, Dr. Jonathan Evans, and he's prepared a slide and going to just take a few minutes to kind of give us the latest, greatest information on what's going on with the COVID-19 vaccination. Dr. Evans, thank you so much for taking a few minutes to be with us today. Are you on mute, maybe?
Yeah, hello, I hope you can hear me. Thank you for having me, and I enjoyed the presentation. I'm sorry to cut into the questions because it's so interesting. But I did want to say a little bit about the vaccine, because I'm sure many of you have been asked a lot of questions and you have questions of your own. So I posed a few questions, which I'll try to answer quickly. What is this vaccine? Is it safe? Does it work? Will you be required to get it if you're working healthcare? How or where or when could you get it, and should you get it? So those are the big questions. And we could spend hours talking about this as well. I'm going to just tell you that in terms of what it is, there are two vaccines that are likely to be authorized by the FDA next week. They're very similar vaccines, and they're unique, and it's a somewhat different technology than has been used in the past. Basically, these particular vaccines, instead of it being a dead virus or a weak virus, they're actually pieces of genetic material, RNA, that end up getting into your cells, and they cause your cells to make a protein. It's called the spike protein, which is the place where the antibodies attach to the virus and ultimately deactivate it or kill it. The stuff in there has to be stored at very cold temperatures so it doesn't deteriorate. So that you probably heard about that as well. In terms of their safety and whether it works or not, let me just tell you that I am naturally skeptical. I'm trained as an epidemiologist to basically tear apart studies and look for everything that could go wrong. And I have to tell you that the effectiveness of these vaccines is so far better than even the manufacturers expected, or any of the scientists involved, or the people conducting the clinical trials. And the good news is that the effectiveness appears to be across age groups. Lots of people over 65 were studied, and they studied a large group of people from communities that have been historically underrepresented in terms of access to healthcare. So in terms of the effectiveness of the vaccine, it looks extraordinarily promising. There's a third vaccine there are a couple of other vaccines that are not as far along, one of which is an AstraZeneca Oxford University vaccine. That's not going to be around for a while, and we can talk about that later or some other date. These vaccines appear to be extremely safe, and there really were no serious adverse outcomes in these vaccine studies. With the AstraZeneca one, there were some question marks early on, and that's part of the reason why it's going to take a while in this country to evaluate that. But like every vaccine, what typically happens is people, you get injected with something that stimulates your immune system, and then you have symptoms of a stimulated immune system, like soreness at the site, perhaps feeling a low-grade temperature or fever, low-grade fever, or feeling achy or something like that, much like other vaccines that people have had in the past. No, I'm not. Let me just tell you, I'm not trying to minimize this or sell anybody on the vaccine. I'm extremely skeptical about all this stuff, especially this one, since I was worried that things were being rushed through for political reasons. I have studied all of the protocols for these vaccines. I've looked at whatever data is available. I'm looking forward to having more data once the FDA makes their decision next week, and I'm happy to report back. But I haven't seen anything quite like this in 30 plus years in medicine. It really looks to be extraordinary, and I attribute it to the particular technology that they used for this vaccine. Now, none of you will be required to get it. Nobody in this country is going to be required to get this vaccine. But I'm telling you that I can't wait to get it. And the reason I can't wait to get it is because, you know, I haven't seen my mom in almost a year. Because she's 80 years old and I don't want to make her sick. I have cared for many people with COVID, just like Jim and others have talked about. I've sat with them as they've died. I have had many patients of my own whose family members inadvertently made them sick, and you know, and I just, the thought of living with that weight for the rest of my life, it really troubles me. And so, you know, I feel that it's not only am I excited to get it, and for my mother and others to get it, but I'm, you know, I feel that it's my my duty to get it, and I'm proud of that. And you know, we've been, as healthcare practitioners and as caregivers for people in long-term care, we've been given a tremendous privilege to be basically near the front of the line. And but on the other hand, the flip side of that is things are being rushed out as far as getting the vaccine out there, and what hasn't happened with the same speed is the education and the communication that's necessary, because everybody deserves to know what this is all about, to have their questions answered, to have any concerns addressed. And but the main reason that I want to get vaccinated, and the main reason that I would encourage you to get vaccinated, is because I view it as an expression of love for people that I care about in order to keep them safe. And having said that, many of you might think, well, I don't need the vaccine because I'm young and I'm not likely to get very sick from it. But unfortunately, people of all ages have died or been disabled from this disease. And so you can't assume that it won't affect you in any bad way. Moreover, you could be perfectly fine and never have symptoms from COVID, but you could give it to somebody else who suffers and dies as a result. So this is what we do because we care for and love other people. And I'm not saying that to make anybody feel guilty or shame you into doing that. So there's that. You've heard that you're probably wondering when it'll be available, especially if you work in long-term care. And there's a couple of sort of parallel processes. There's a federal program that's basically going to distribute the vaccine in nursing homes and assisted living facilities. But in addition to that, that vaccine is coming straight to the manufacturers, from the manufacturers to the pharmacies like CVS and Walgreens that are going to be responsible for distributing that. The community or facility where you work by now will have completed a survey from the federal government indicating how many doses you need, and it'll include staff and residents. Nursing homes will be prioritized over assisted living, so nursing homes will be vaccinated first and then assisted living. So if you're in a CCRC, that'll happen in your community as well, in the same way. And if you're a healthcare worker, you have the choice of being vaccinated at the community or going to a hospital or a clinic, another place where the vaccine may be available. But what's going to happen is, for all of us that work in these communities, the community is going to be given in communication with the pharmacy provider. They're going to come in and do all the vaccines. They're going to bring all the stuff. You don't need to, they just need a space to do this. They'll go room to room for people who are immobile. They're not going to vaccinate people who are currently COVID positive, or, you know, or because there's no guidance as to whether or not those people should be vaccinated yet. They're going to provide their own PPE and everything. They're going to need a space, probably a well-ventilated room if possible, and some assistance getting people there back and forth if they're mobile enough to be vaccinated there. Then what'll happen? So I just had this meeting with Walgreens, and they don't know exactly when they're going to get it. Each individual state has the go button, so to speak. So each state will tell them when they're ready for post-acute and long-term care settings, okay? And then at that point, the pharmacies will contact us, and they'll basically say, they'll start talking about dates, and they'll want to get a list from you about 2 weeks in advance, or not a number of how many people. They're going to provide consent forms, but it's up to individual communities to get surrogate consent from people, for family members and others for residents who cannot provide consent themselves, okay? And the reason why there hasn't been a lot of information provided is that the FDA is not allowing people to provide materials that they haven't approved of yet as part of this emergency use authorization. So any educational material that you've seen so far has been fairly bland and generic and so forth. And I'm sure you have other questions about that, which I'll try to answer or in some way if I can. So each community will be notified by the pharmacy provider that you signed up with, and they'll give you sort of further instructions. They're going to want, even though the vaccine is free, they're going to want insurance information. Medicare Part B will pay for the administrative fee for people who have Medicare, and for staff, they're going to ask for other insurance information to cover that $15 to $20 administrative fee. But at least as far as Walgreens is concerned, I don't believe that they're going to come back after people for payment if they don't have insurance. They understand people are underinsured. They're getting paid to do this program, and the general public has been told the general public's been told this vaccine is free. So having said that, there's a lot of distrust of vaccines. There's a lot of distrust of so-called experts, especially people that look like me. And that, I mean me personally, I don't mean, any group that I belong to, okay? There's a distrust of me, okay? And it's well warranted. By the time patients get to me, they've had a lot of health care, and that means they've had a lot of disappointment. And the staff that I work with, many of them have had a lot of difficulty accessing care, and their experiences haven't been that great either. And so here's what I want to tell you. A very large proportion of the population doesn't want to be vaccinated right now. Many of them are healthcare workers. And unfortunately, if they don't get vaccinated when it's offered to them, they have to go to the back of the line. So you can't decide, well, I'll get back to you tomorrow. Because so these pharmacies are going to provide 3 dates basically that they're going to, with you all, to decide when they're going to come out and do this. And that allows for the second dose to be given, because each of these has a booster shot. It's either 21 days or 28 days, depending on the vaccine. But information is obviously critical for people to make their own decisions about what to do with the vaccine. And so there will be a lot of information given in different languages and so forth, but information is prerequisite, but it is insufficient for behavior change, okay? And for something like this, ultimately people have to feel for themselves, and I say feel, not just think, that it's safe. They have to be able to trust the vaccine. They have to be able to trust the people who are offering it to them or telling them that they should get it. And as a consequence, I don't really expect people that don't know me to trust me, okay? And most of us are highly influenced, if not all of us, by people we know well, by our peers, in terms of whether we're going to change behavior. And so I would encourage all of you in all of your communities to start now thinking about how you want to communicate with others, involve peers in educating other peers, celebrate the fact, the people that are getting vaccinated, and make it as conspicuous as possible. If it wasn't for the pandemic restrictions, ordinarily I would be recommending that you have a party about this, and if you can, in a socially distant or physically distant appropriate way, more power to you. And I also want to emphasize that the last thing I want to happen is for people to be shamed about not getting vaccinated. There are people may have a number of concerns that can't be addressed by the information provided, and it's not that people will never have another chance. It's just that the supply is limited, and so each of us has been given a privileged position. And if we don't want it, or don't want it now, there are plenty of other people waiting in line that would like to have a turn. So anyway, I could talk for a long time, but I'm not sure I'd say much more. I'd much rather respond to individual questions or concerns that people have.
Yeah.
And I'm not somebody that loves getting shots or that thinks all vaccines are great. There have been plenty of vaccines that I haven't gotten, like the shingles vaccine, because I had shingles recently. When my kids were little, the chickenpox vaccine came out, and I wasn't terribly interested in having them be the first people in the country to get the chickenpox vaccine. So I'm just want to let you know where I'm coming from is a position of, show me, prove it to me that it's effective. Don't just, I'm not just waiting in line to do what somebody else tells me to do.
That's fabulous. And we do have a couple questions that I'd like to put there to you.
Sure.
Dr. Wright was asking, have you seen any data about the vaccine's effectiveness after the first dose? In other words, will recipients have some protection after the first dose?
Yeah, I haven't seen that data yet. It hasn't been shared publicly. I expect to see it next week or by the end of the week after the FDA issues their emergency use authorization, and they will publish that on the web immediately along with their release. The assumption, but this is an important question because, the expectation is that there is some protection from the first dose, but there's a booster shot with the primary aim of trying to extend how long that protection lasts, because with coronaviruses specifically, it appears that the immunity doesn't last a lifetime or even as long as some other things like tetanus shots. So the whole purpose of the booster shot was to make it last longer, but the expectation is that there'll be some benefit fairly quickly after the shot. And we're not going to get to choose which vaccine we get right away, but the choices, but the two that are available, I would be happy with either one. I would be much more concerned about other vaccines like the AstraZeneca one that seems to have a lower effectiveness rate that I still have some unanswered questions about. If that was the only vaccine available, I'd still get it, but these two are, in my opinion, appear to be better thus far, but more to come on the others. And by summertime, people will probably have a choice of vaccines as they do now with other things if they're available.
All right, I'm going to give you a couple of them right now. So residents that are currently positive won't be vaccinated, but what about those that were previously COVID positive, but they've recovered? That's the first one. And then the second one is about research done on pregnant women.
Yes.
And been approved for, has it been approved for these staff members?
Yes, so excellent question, very important. And I just want to emphasize the vaccine hasn't been approved at all in this country. And and the so-called approval, technically speaking, will be what's called an emergency use authorization. So it's kind of a fast track. It's not, and there will be additional monitoring afterwards for at least a year for everybody that's vaccinated. By the way, if you get vaccinated, they'll give you a card, a vaccine card like the old days, that will remind you about, it'll say the lot number to make sure you get the correct second dose, because there may be two different vaccines. But also ultimately that card is going to be needed for travel and other things in all likelihood, just like it is now if you wanted to go to certain parts of the world where diseases are endemic and stuff. But in our case, people outside of this country are concerned about Americans bringing the virus to the rest of the world. This vaccine has not been tested in pregnant women, although women have gotten pregnant during the trial. So there is some evidence in that group. However, because it hasn't been specifically studied in pregnant women, the FDA has, the CDC and the FDA both have issued no guidance on that. And I don't expect them to until additional studies are done. So they're going to probably recommend that people that are pregnant not be vaccinated at the present time. There have been a number of studies of COVID infection among pregnant women, and the outcome for children born to people with COVID is generally quite good, but there have been some concerns raised there. This has not yet been studied in children, so it won't be authorized for children. Those studies are beginning, and in all likelihood, there may be a vaccine available for children by the fall, optimistically. As far as people who've already had COVID, the CDC has a statement on its webpage that basically says, we don't know whether or not we don't have any data, therefore we don't have any guidance. But I think what will happen though before long is that, just like pretty much every other vaccine, is that if you've had the disease previously, but there's a question about whether you had it or not, then just like with the shingles vaccine, for example, they'll recommend that people who have already had shingles get the shingles vaccine. Well, they'll probably recommend that if you've had COVID or if you think you had COVID, and it was more than 3 months ago or something like that. And I'm making this up because it's conjecture, but in all likelihood, in the future, they'll say, if it's been more than X amount of time, we recommend getting the vaccine, even if we haven't studied that specifically, because we have evidence that some people have gotten COVID twice even with different strains. So I do expect down the road, there will be some guidance around that, but it won't be happening in December. But some of this vaccine may be available in certain states as early as, after December 12th, for example. That's when the FDA will issue its ruling. So the vaccine is already in various states. However, it's not going to be in nursing homes or assisted living facilities on December 12th. Realistically, it'll be perhaps January, most likely. And if it's anywhere in mid-December, it'll probably be hospitals or large clinics or something like that. And staff of long-term care communities can get their vaccine at a clinic. They don't have to get it on site at the community, but there will be enough vaccine at the community site for all the staff.
So real quick question, and then I would love Carol to comment about kind of where things are with them. And I do recognize the time, and thank you for hanging in. So question, residents who have Guillain-Barré syndrome, is there any data on whether or not they should get the vaccination?
Well, there isn't yet, but that's a very important question, because Guillain-Barré syndrome is the biggest worry about vaccines in terms of serious adverse effects tends to be neurologic conditions like Guillain-Barré. And in the AstraZeneca trial, not one of the vaccines that we're talking about, but in another coronavirus trial where they actually do use a different kind of virus that inject with you, there were a couple of cases in the trial of people having acute neurologic symptoms. It wasn't Guillain-Barré per se. One person had MS, another person had what's called transverse myelitis, which could be the beginning of MS. It also could be theoretically, either of those could theoretically be a vaccine side effect. And most people who have Guillain-Barré are usually are very worried about taking vaccines for fear that it might somehow cause a flare-up. I do want to emphasize that for this particular vaccine, because it's not a live virus or anything like that, the risk of having a serious infection is zero, basically. But the risk of having Guillain-Barré is thought to be, what the worry is that some people might have an overzealous immune response, and it could cause that. And Guillain-Barré, fortunately, is very, very rare from vaccines, but it's something that has been seen with a number of vaccines at a rate of, we're talking about one or a couple cases per million. So, the odds are more or less 1 million to 1 that you're not going to get Guillain-Barré from a vaccine, but the odds are less than 1 million to 1 that you win the lottery, but somebody always wins the lottery too. So, and again, that's why I want to say, this isn't something where if you don't get it, you're a bad citizen or bad person. This is a highly personal decision. You need to consider your own health. But I'm just telling you that among vaccines, this is as good as it gets from what I can tell so far. And I don't say that lightly.
No, and that's what I appreciate about having you on. And Carol, I just, at the very beginning of our call today, Carol shared some really good news that they had received relative to the vaccine. Carol, do you want to share your news?
Sure, and thank you for those comments about the vaccine. It's really helpful. We were notified today that we will be receiving the vaccine either December 14th or December 21st for our long-term care elders and our staff, and our assisted living is going to be right behind it. So here in New Jersey, they're moving quickly to get long-term care. They're actually putting us ahead of the acute care settings. So we are meeting as a team tomorrow morning actually to go through our protocols with respect to getting the consents, talking to the staff, blah, 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 blah. If any of you would like that after we've developed it, just let us know. We'll be happy to share it so you don't have to reinvent the wheel.
Thank you for that. And, just to comment, and Jonathan, I'm going to talk to you about coming back for our final ECHO session, which will be after you all have, in theory, received your vaccines and done some things. So I think we will kind of structure our last one to really talk about some of this. But I'm going to ask one final question to you, Jonathan, that has just come in. The virus has an inflammatory response. What about people who already suffer from a heightened inflammatory response?
Yeah, so just to clarify, inflammation is a phenomenon something your body does in response to things. And, you know, if for example, you know, exercised or something like that and you got sore muscles, that's because those muscles or joints or whatever have become inflamed from that. It's a normal phenomenon. It's not automatically a sign of infection or anything like that. But in some people, and presumably based on some genes or something, and possibly even some infections in the past, some people have conditions whereby the immune system gets turned on, or this inflammatory process gets a little carried away. Okay, and there are a whole host of conditions which we think of as sort of autoimmune conditions where that's the case. And as a consequence, a person has an autoimmune condition or something where the inflammatory, you know, the body's inflammatory response is already revved up. There's always the concern that, at least in theory, that if you introduce something else foreign into your body, that you might have an overzealous response and might have symptoms. In this particular case, that would be manifest. You might be more likely to maybe say get a fever or have more, you know, achiness or something like that as a result of getting the shot. There's no, these trials did not exclude people with those conditions. They didn't exclude people that were taking immunosuppressive drugs. And that's the other thing is, if you have a, you know, autoimmune condition or increased inflammatory response, chances are you're taking some kind of anti-inflammatory drugs, which can lower your immune response. But it's safe to give this medicine in that population because it's not a live virus. There are certain vaccines you would avoid because, in theory, they even though they've been weakened, but they're alive but weakened, they might be still strong enough to cause you harm. So this is one where there are far fewer worries about that. There's no worry about egg allergies. Chickens weren't involved in the development of this vaccine or anything. But I would say, the details that we're talking about are critically important things for individuals, and you should not get the vaccine if your concerns have not been addressed to your satisfaction. Okay, even though, I mean, there's this artificial, I mean, obviously we've been dealing with this for the better part of a year. It's been the worst public health tragedy in over 100 years in this country, and it needs to end, and it needs to end now. But for you individually, if you're taking appropriate precautions, you can protect yourself from the virus now. And even though this vaccine is something that will likely benefit most of us, take your time, especially if you have underlying health concerns, to make sure that you have the best information to feel safe that this vaccine is right for you or people with your condition. And if you don't get vaccinated, I personally am not going to love you any less, okay? And I hope nobody does, because, if you're on this call, you're somebody that cares about other people, that puts service ahead of self, that wants to be part of something bigger than yourself and make the world a better place. And that's why I love you and I want to be more like you. And that's why I'm here, so you can make me better, and you do. So thank you for being concerned. If you're concerned about that for yourself, it speaks volumes about the concern that you have for the people entrusted to you, and I'm grateful for that. But I'm really, like I said, I'm not here to sell anything. I'm here to tell you that I've been extremely critical and skeptical, but my concerns for me and for my mother have been satisfied. And I'm somebody that, given my role, I would accept a greater degree of risk. I was prepared to accept a greater degree of risk for myself, because I feel like I have I've been given a lot, and I have a unique obligation to give back and so forth, and I want to set an example. But I don't expect anybody else to. That's a personal decision, and fortunately for me, I'm not going to have to settle for some crappy, pardon the expression, great value vaccine or something like that. This is the good stuff, so to speak. If there, I don't mean to minimize it in that way. Okay, and but and as was mentioned earlier, and I think it was Naomi that said this, we're all going to be okay. I mean, this is all, things are going to get better. That doesn't mean that people won't suffer, or that even some of us on this call won't get sick or worse. But as human beings, as a group, as people, we're going to get through this, okay? And this is an important tool that can help us get through it a lot faster and ease a lot of the pain, not just for individual people, but just the economic and social suffering. So I'm here to share that good news, but I don't want anybody to agonize over it, okay? It's not worth that. I do that all the time. I worry for you, so you don't have to worry yourself, okay?
I think those are really wise words, and words to really take to heart. Thank you, Dr. Evans, for being with us today. And it's helped me to think about how to shape our final session, which will be on December 17 at 3 o'clock. We're going to kind of put it all together, wrap it up. I've asked Eric and Dr. Power to kind of put forth kind of their top 10 best recommendations. But in addition to that, in context of today's conversation with Dr. Evans and really thinking about what we want to be thinking and doing about the vaccines, their questions continue to pour in, but I do want to respect everybody's time and thank everybody profusely for joining us. Carol, Naomi, Eric, thank you so much. Dr. Wright, thank you for your time today. Thank you for your presentations and for sharing your very personal experiences. And we will get through this. So thank you, everyone. Be safe until we meet again. And we'll be looking forward to sharing new words of wisdoms when we talk again on December 17. Take care, everyone. Have a good week.
Thank you all.
Thank
Thanks
you.
to my new buddies. Good to see you. Okay.
Thanks, Jonathan.
All right, bye-bye.